this clinical minute, we'll be discussing an insignificant risk retrospective chart review of outcomes after topography-guided LASIK using two different protocols. Dr. Karl Stonecipher is here to discuss the results and their implications for treating patients during the COVID-19 pandemic. Karl, thank you so much for being here to discuss your study. This is really exciting. I'd also love to hear any other pros you have in optimizing refractive surgery.
Sure, absolutely. I mean, it's really cool to be here. Finally, we're all with everybody and seeing all our new friends. So it's really great to see you guys again. Today, what I really want to kind of concentrate on is, TCAT, topographic guided. It's been around for quite some time. Now we just got a kind of a new analytic engine that's doing vector analysis of the front surface of the cornea, the back surface of the cornea, the lens, okay, and then your manifest. It throws all that GUI in together and then comes out with an axis and amount of astigmatism. You're still doing your typical, how do I analyze this? You still have nomograms. There's still needs for all that, but it's made it so much easier in terms of the GUI for you, the surgeon, everything. And then on top of this study, the biggest pearl that I want to tell everybody is COVID was really good to us for efficiency. We got better. Mm-hmm. So what we ended up doing was doing a study, which is part of this group, and we showed that we're actually a little bit better post-COVID in terms of outcomes. Our enhancement rates right now are 0.29%. So that's what I always look at. So people think of an enhancement as a failure. So what we did before COVID was a typical manifest, cycloplegic, diagnostics. Is that what you do? Mm-hmm. I mean, you typically do. Yeah. And then post-COVID, what we decided to do, okay, we're going to get this device, which is called DRS Plus. So we can do wide camera pictures. Now, if you're really highly myopic, if you've got, astigmatism, like mixed astigmatism, a lot of hyperopia, something like that, we're still going to cycloplegia, but everybody else we manifest. So we manifest that person. Then on the day of surgery, they get their diagnostic. So we use drops before to kind of tune them up. Day of surgery, they do everything. They've already paid their money. They've already been consented. So the average time in our office is 45 to 50 minutes. It's amazing. They never see another patient, and they're like, I don't ever see anybody else in your office. I said, that's by design. So they come in. The one thing that's interesting that you need to know is text messaging. So that's part of our consent. So we say, can we text your loved ones? Well, they're like, I'm okay with that. But legally, you've got to have that in a consent format. So we text them. And then we got rid of 2 visits. So we see them on post-op day 1, of course, and then we see them at 3 months. That's our analytic visit. But at 1 week and 1 month now, we just call them by telemedicine. Say, hey, how you doing? If they say, hey, I'm doing awesome, and I haven't seen this good, then they, stay doing whatever they're doing. If they're saying, I'm not doing where I think I should be, they come in.
We're doing something very similar. We're also doing virtual consults and such, and virtual follow-ups for some of the visits. And as you said, with refractive patients, it's very much amenable to that. So,
and they don't want to come in if they don't have to.
Yeah, exactly. And is this all spelled out in your paper?
Absolutely.
Fantastic. Yeah. And this is exactly what we hope, that everyone will go to that fantastic paper that you have worked so hard on, and we can maybe mimic some of the pearls that you have around refractive surgery. Cool. Thank you so much for being here and contributing more and more to our field.
Thanks for having me.